Okay. Hello, my name is Gwen Driscoll. I'm the Director of Communications here at the UCLA Center for Health Policy Research, and it is my pleasure to welcome you once again to the last of our 2015 Health Policy Seminar Series, and also to today's big question: why don't more community clinics provide on-site dental care? Our two speakers, Dr. James Crall and Dr. Nadereh Pourat, published a recent study on this issue, and will expand upon their findings in today's seminar. In particular, they will look at the county with the most clinics, yet with very low rates of primary dental partnerships in the same facility, what we call co-location. Before we begin, however, just to note that we will be taking a break in the month of December, but we will be back with you in January for a new seminar and a new year of our Health Policy Seminar Series. So stay tuned and subscribe to our e-newsletter, Health Policy News, and that top link in this slide will tell you how to subscribe if you're not already subscribed. You can also view recent seminars on our newsroom, and we will be recording this seminar, and you'll be able to view it probably in a day or two. And if you would like copies of today's presentation slides emailed to you, please email me at gdriscoll@ucla.edu, and that's that bottom link on this slide. Please note we will also have a brief question and answer period at the end of the seminar. Okay. I'm now happy to introduce the co-presenters of today's seminar, Dr. James Crall and Dr. Nadereh Pourat. Jim is a professor at the UCLA School of Dentistry and chair of the Division of Public Health and Community Dentistry. He received his DDS and MS at the University of Iowa, another MS in Health Service Administration at Harvard University, and just because he enjoyed the weather in Boston so much, he stayed on to receive a doctorate at Harvard in Health Policy and Management. Jim has long been interested in how to bridge the gap between care and community. He has been the principal investigator of several studies on how to improve integration on how to better integrate health services, most recently with funding from First 5 LA to improve integration of community-based dental and primary care services in Los Angeles. He has also received major grants to help pediatric dentistry residents to engage in community health and advocacy training. And he has led a national initiative focusing on expanding dental homes for Head Start children. Nadereh Pourat is the Director of Research and the Director of the Health Economics and Evaluation Research Program here at the Center. She is also a Professor of Health Policy and Management at the UCLA Fielding School of Public Health, and she's an Adjunct Professor at the UCLA School of Dentistry, amongst other appointments. Nadi's research focuses on assessing disparities in access to care of underserved populations, including the role of the healthcare delivery system in disparities in healthcare outcomes. She has taken a particularly in-depth look at the role of dental care delivery systems in access to oral health care, and has written numerous center studies and policy briefs on oral health care access and impact. In September, Jim and Nadi published Better Together, Co-Location of Dental and Primary Care Provides Opportunities to Improve Oral Health. In this study, they found that only 3 in 5 community health centers had dental care on site, and that patients were forced to travel 5 miles or more to get dental care at more than 100 community clinics statewide. Here to tell us more both about the problem and some possible solutions, it's my pleasure to introduce Dr. Jim Crall and Dr. Nadereh Pourat.
Thank you, Gwen. Having gone from the Midwest to Boston, it was in fact like a sort of a move into a milder place, but having been here at UCLA for 12 years now, I've become completely spoiled, and very happy to be here and happy to work with colleagues here at the UCLA Center for Health Policy Research. I'm going to start with providing a bit of context for the actual study that was done. And then Nadi will get into more detail in terms of the methods and the findings, and then we'll talk at the end. We'll wrap up with some policy considerations. So, as you probably know, oral health care is still a pervasive challenge throughout this country, particularly for low income and uninsured individuals. The burden of oral disease, I think, is increasingly being recognized as being important for the general population, but particularly among low-income populations. It's often reported as the greatest unmet health need for individuals covered, whether they're uninsured or covered by public programs, and dental decay is still the most common chronic disease of childhood in this country, with CDC reporting over 42% of 2 to 11-year-olds having had cavities in their primary teeth. Here in California, we know from the most recent statewide survey that was done that 54% of California children have experience with cavities by the time they reach kindergarten age, and it's 71% by third grade. So there's still lots of work to be done in this area. 23% of kids nationwide, young kids, have untreated cavities, and so access to care is a big part of that. And we know that overall throughout the country, only about half the kids in the country actually have a dental visit in any particular year, and there are disparities, significant disparities in that, with privately insured and kids from more well-off families. That figure would be roughly 60% or a little higher, but if you're looking at uninsured or even many Medicaid insured children in low-income families, that'll be 30% or less. And, ironically, those are the kids that have the greatest needs for care. So lots of work to do. The good news is that we have evidence that early interventions, preventive interventions, can pay big dividends. So it really underscores the importance of starting early and working together with our medical colleagues. And so that has led to the desire for some system change. There we go. The barriers, dental insurance still is a barrier in that not nearly as many people in the U.S. have dental insurance compared to the penetration of medical insurance. Even those that have insurance, the way the benefit is structured, oftentimes there are co-pays, and particularly for low-income families, that can present essentially an ultimate barrier. Rand Health Insurance experiment showed that 30 years ago, that even small amounts of co-pays can be a significant deterrent for low-income people. Out-of-pocket cost, really can just keep people from seeking care entirely. And on the Medicaid side and in the private dental sector, many dentists do not participate as Medicaid providers. Part of that, and a significant part of that in many states, is the reimbursement levels for providing services. And unfortunately, California has a lot of work to do, I think, in that area as well. Our reimbursement rates for dental services and Medicaid are among the lowest in the country. Community health centers, including federally qualified health centers, play a significant role in providing basic primary care services for low-income and uninsured segments of the population. But as we pointed out in the brief, and it was repeatedly pointed out in a national conference that I just returned from, of the dental programs in community health centers, community health centers only provide dental services for about 20% of their patients. So, that led us to ask what's the situation in California, and to try to get some data that we could get a better handle on the situation in California. We know this, the FQHCs, the federally qualified health centers, and their lookalikes are required to provide preventive dental services, but many of the people who seek services, health services in community health centers, need more than preventive services. We also know that many community health centers throughout the country do provide at least basic dental services, routine fillings, some of the less extensive types of periodontal treatments that would help people in that regard. And so the evidence suggests that co-locating those services is a good strategy to facilitate greater access to care and utilization by groups within the population who need these services most. So that's the background for the rationale for conducting this study, and now Nadi will talk about the methods and the findings from the study.
Thank you, Jim. So we set out to ask the question, we needed to understand the lay of the land, how many of the community clinics in California actually have co-located services. And this is how we did it. We looked at the data from the California Office of Statewide Health Planning and Development, OSHPD, because all of the community clinics in California report their information to that organization, and we actually had quite a bit of data at the organization level, the site level. And we looked at the data for 2013. Our sample included all of the CHC sites that reported their data in 2013 were actually operating in that year, and also employed or contracted with a primary care provider, and we defined those as physicians, physician assistants, and nurse practitioner. That was important for us because we were looking at co-location within organizations that provide primary care services, and some of the organizations that report in the data set don't actually have physicians and nurse practitioners, etc., on staff, so they might be doing some specialized services, and we wanted to just look at the ones that provided primary care. In terms of the methodology, we also used to assess dental capacity, we looked to see who actually employed, contracted, or had on staff dentists and hygienists in alternative practice that might be able to have provide additional dental services, and also any of the organizations that reported some dental visits, even if they are not reporting a dentist, because they might have arrangements with another one of their sister or sites, and they might be actually providing services even though they don't directly pay for that person. One other thing that's interesting about this data is that community clinics are sometimes big organizations that have multiple sites. We wanted to only look at the site level, but for some of the analysis that I'm going to describe, we actually look at the parent organization or try to see what's going on within those organizations, because we might have missed some important facts. We excluded the mobile sites because we could not assign them to a specific location. And for the analysis of the distance, we also included the dental sites, dental-only organizations within those multi-site organizations. And I hope it becomes more clear as we go ahead. The total sample, we ended up with about 886. It's about 78% of all of the organizations that report to OSHPD. And there were about 751 that were multi-site organizations. And there were 48 dental-only sites in those organizations. Okay, so here's the top-level look at how this worked. We found about 292 sites in our data that actually had dental providers on site. Of interest is that not all of these sites that have co-location employ a lot of providers. So we cut it off at about a 0.5 full-time equivalent dental provider, which is really only capacity to provide about 1,000 visits a year. And that is, that's really about one person for about 13,000 or more people. So you can understand when we say capacity, how small a capacity it is in some of those co-located organizations. The rest of them, over 70%, 77%, I believe, actually provide significantly more capacity. Then the ones that were part of multi-site organizations, we thought that you can't just look to see whether they are co-located. Maybe they have another facility within their organization they could refer people to. So there is some capacity there. And you can see about a third are falling into that. This is including about 8% that have a facility relatively close by, perhaps walking distance, 1 mile. And then there are those that their actual capacity is greater. So most likely you need a bit of transportation extra preparation to go to have a visit at the dental site. You cannot do anything like that in one day. And about a third didn't have any capacity in their organization or in the bigger part of the parent organization. We also looked to see what's going on statewide. Are there regional differences? And as you can see, the answer is yes, there are regional differences. Some of the counties in the Northern California area, dominated by a lot of rural areas, they actually co-locate. And this is a very practical matter for these organizations. You cannot, there is nobody else perhaps nearby that would provide services, so they actually take that additional step, and there are probably more considerations for them. Alternatively, of interest is Los Angeles County happens to have the fewest number, or proportionally fewest, co-located organizations in the county. Next, we looked at how do they differ? What else is going on in these organizations? What's happening with their staffing? What's happening with their revenues? Can we figure out what might be contributing? Or can we at least characterize these organizations a little bit more? And we found that when we look at the co-located organizations in California, we find that they are generally bigger organizations. As you can see here, this is the total number of providers in the organization and their clinical and administrative support staff that help provide services. And so you have a large organizations as compared to the ones that are not co-located, but they might be part of an organization that provides dental anyway. And then there are those that have no capacity, tend to be overall slightly smaller organizations. A little bit of comparative, the co-located sites have at least 2.5 times more providers and staff than those that are not co-located. They also have 1.6 times more patients, 2.3 times more encounters, and 3.3 times more total revenues. And you can also see that they do have more patients that are actually Medi-Cal insured or beneficiaries than the ones that are not co-located. So you can see some significant differences. The other interesting thing is that they actually co-located actually do see more children, but that's all the children that are receiving services in that organization. It does not necessarily mean all those children are receiving oral health services. So that's perhaps an opportunity there to help. When Jim was talking about early prevention and the importance of that, that's one area of opportunity there. Then we sort of took a closer look at those multi-site organizations and what's going on there. How far are the sites with dental capacity? And here you can see that for a few of the sites, there's about 6 of them here, 13 here, and 6 here, where the distance is really short. We actually walked the hall trying to figure out what is 0.01 mile. Very, very near. We think they are primarily, next to each other or within, around the block, very close. But that's a very small percentage. Most of them are over here with a significant, well, not most of them, but a large number are with over 5 miles distance. And now if you can picture someone who might have taken the day off from work, has about 2 or 3 kids in tow, and you come in to the organization and you are able to receive the medical services, but you could as easily have scheduled a dental appointment as well for the kids to get a little bit of prevention, or for yourself. The situation, that sort of highlights why co-location could be so helpful. And also people who transportation could be a difficulty for them, even within 5 miles, that then you're talking about, I don't know how many buses, depending on the location that you're at. So that's part of the reason why we focused on the distance to the nearest dental site with dental capacity. So those were the results from the policy brief that hopefully you have seen already, but we also try to do a little bit more, understand what's going on in LA County, especially because the number of co-located sites or the proportion of co-located sites was quite a bit lower. And so we did a little bit more digging in LA County. One thing to understand about the background in LA County, not only we are a very large county in the state of California, we also have a large number of population that is low income and uninsured. So we have that going for us. We also have a demonstrated level of poorer access for the population that's low income. And that's what this slide is showing. We looked at the California Health Interview Survey latest data in 2014 to see what people are reporting at their poverty level, what is the last time that they had been to the dentist, and we considered having been to the dentist in the past year as a timely visit. I think the requirement, the recommendations for timely visits are even a shorter time frame, but we're just sort of being a little bit more conservative and using 1 year. And as you can see here, we find that in the Los Angeles area, children that haven't had a dental visit, their larger proportion are actually below 200% of federal poverty level compared to California. We looked at the adults, and we also find a larger proportion of the low income that actually have not had a timely dental visit. So compared to California, and this indicates there is certainly need, and there's most likely significant demand. And now we're going to look a little bit at how Los Angeles differs in the characteristics of the organizations that are not co-located or are co-located. So hopefully I don't lose anybody in this slide. We are looking at the ratio of the providers and their clinical and administrative support staff. And that is important because the more support and administrative staff you have in a community clinic, the more capacity you have to do additional things for your population. If you want to integrate medical and dental, you have to do more work. It is not as simple as a desire to do so. You have to put a lot of different things in motion. You have to do a lot of activities to make sure that this thing happens. Maybe you need to walk your patient from the dental side to the medical side or vice versa, and you need a person that would be responsible for those kind of activities, referrals to the dental side, etc. So there are resources required for integration, and you can see that in the co-located capacities in LA County, there is a higher, the ratio of the support and clinical staff to provider is a little bit higher than the counterparts California-wide. So that's nice. However, you can see the ones that are not co-located in LA County actually have a little bit more capacity for delivery of care. We also then looked to see the actual productivity and the panel size. And the way we did that is we just took a simple ratio of the total number of encounters or visits to total providers. And also we looked at the total number of patients to providers. We didn't have enough information to do this at the dental level only. So this is all providers in the organization. And you can see that when I talk about big productivity, I mean they were able to provide more services, more visits, and this is what we're talking about in the co-located sites. And if you're looking at actually the number of patients per provider, this is the number over here. So for the co-located organizations in LA County, this ratio is actually greater than in California. So a little bit more care provided over there, and also the panel size is a little bit larger. So these providers are actually potentially taking care of more patients. These differences are not that great, as you can see, but they could still have implications, and perhaps they are pointing, though we're not exactly sure how, to why the co-location rates are lower in LA County. We wanted to also understand a little bit more about where the revenue sources are, what the revenue sources are for these organizations, particularly because if you are depending on grants primarily, which are provided to federally qualified health centers, the money is really to help these organizations to provide care to uninsured populations. And so if you have more insured patients, whether it's Medi-Cal, Medicaid, Medicare, or other sources, you actually have the potential for more revenue to the organization. So we are looking at the comparatively across the board, and you can see that the LA County co-located clinics received a lower proportion of their total revenues from their patients, and more of it coming from the so this is the number I'm talking about here, the patient sources, of course, just to be clear, as opposed to the co-located sites California-wide. So perhaps this is a question of resources, but of course more analysis is needed to really understand. Okay, so I think I'm done with this part, and Jim Crall is going to talk about the implications of these findings.
So as other evidence and our findings show, that these co-located sites do demonstrate the potential to provide services to more patients. So that makes that, again, one of the important strategies to use to try to deal with this issue of low access to care and utilization of care for either uninsured individuals or publicly insured or low-income individuals. The question is, what would it take to make that happen? And the general answer is it would take more resources. That's a finding that's actually been recognized at the federal level. The Health Resources and Services Administration for over 15 years now has made policy changes and provided funding to allow health centers to expand their capacity to provide dental services. And fortunately, that emphasis is continuing. There's two components of the infrastructure that are generally required. If you don't have a clinic that's outfitted to provide dental services, obviously you need equipment and you need to do some renovations, capital improvements, and that's certainly something that's been pursued. And in fact, starting around the year 2000, any health centers, FQHCs, that were looking to either become new FQHC sites or to expand their FQHC operations were required to actually include a dental component, a dental service delivery component as part of that process. The other component is human resources. So it's one thing to build the clinic and outfit the clinic, but you have to have people and trained people, providers, to be able to provide those services. So there's got to be an ability to attract and retain dental providers in the FQHCs as well to make this a viable operation. And as I said, fortunately there has been some effort at the federal level to make that happen by providing resources locally. I know that First 5 LA has helped many of the clinics in Los Angeles County acquire additional infrastructure, help with their IT systems, help with some physical renovations and outfitting a clinic. So there have been both federal and local efforts in that regard. We take the opportunity within the presentation to highlight an additional policy potential to address both workforce needs and expand access to care through these types of initiatives. There have been various types of efforts sponsored by the Robert Johnson Foundation, California Endowment, to really expand the training of dental personnel into community-based sites so they can get experience working in these facilities and working with these populations. we'll reference at the end another report that I authored for the National Conference of State Legislatures some years ago under a contract with HRSA that suggests the potential for using community health centers for training programs as well. So that could potentially be a source of a pipeline of providers, the human capital that's necessary to expand these services in these sites, as well as access to additional services. I mentioned that there has been this emphasis and expansion over the last 15 years or so. This graph shows some of the results of that investment, increase in number of patients, dental patients seen at FQHCs across the country, as well as the number of encounters or visits provided to individuals, a 29% increase just from 2010, and that continues a trend that started earlier. Still, we recognize, as I said, that only health centers are only providing services to about 20% of the people who are seeking primary care services there, so lots more to be done. The current opportunity, recently announced by HRSA, approximately $100 million to be available nationwide in supplemental funding to grantees, health center grantees, to expand access to oral health services. Up to $350,000 they can obtain, part of which can be used in the first year for the capital improvements to outfit the facilities to provide the services, and other funding for other uses that the health center might have, perhaps even attracting personnel or staffing to make it a startup operation. And they can apply to expand their oral health services. So in closing, if you haven't read the brief, it's available at the link that's shown here. The report I mentioned on financing dental education and using community health centers as possible sites for both expansion of services as well as training, workforce training initiatives is also highlighted here. We definitely want to acknowledge the generous support that has been provided by First 5 LA, and this particular policy brief and the analysis that was done was provided with support for that. It's part of two projects we have that are currently funded from First 5 LA to work on expanding the capacity of health centers to provide services for young children and pregnant women, and integrate the primary care services and dental services to better serve their populations. So with that, I think we may have time for some questions.
Okay. So I'm going to take questions from online and from the room equally. Can I leave it on? Because I have a question for you folks.
Good.
I was very surprised at the beginning of the presentation by how many very young children have cavities. Why is that? What is the cause of that? I'm sure there are multiple causes.
Well, there are multiple yeah, there are multiple causes. So the question is some surprise about the extent of tooth decay or cavities in very young children still in this 21st century. And there are multiple causes. Part of it has to do with the fact that there just really hasn't been an emphasis on oral health care for young children. And in fact, our First 5 projects, one of the goals of the project is to increase awareness on the part of caretakers and providers about the importance of oral health starting early. We just haven't emphasized that, we need to start brushing young children's teeth with a little bit of fluoride toothpaste and the great benefits that could pay. It's probably happening in more educated segments of the population, but we just haven't, done a good job of highlighting that message, and particularly in the more at-risk groups. There's also there's a professional component of that. It hasn't been an area that's been emphasized either in the preparation, the education of dental professionals, and certainly not medical professionals. But I think there's been an awareness over the last 10 years. The American Academy of Pediatrics now has a pediatric oral health section where dentists and pediatricians and others can work together on these issues and have created programs. So it's starting, but historically we just have not emphasized this, and the result is that all of those antecedents that can create tooth decay are there. And we just need to do a better job educating the public and then providing the access to the services by providers who are willing to take care of these young kids. Yes.
I was interested about some of the comparisons you made between community health centers that were co-located or not in LA County compared to California. And in one case you indicated that those co-located in LA County had a higher visit to provider ratio than the state. And I was wondering if part of that was driven by possibly greater demand in LA County, or if there's something else going on there.
Right.
All right. So yes, the question relates to comparisons between LA County co-located facilities and California co-located facilities, and the higher visits to provider ratios that we see in LA County versus California, and whether that might reflect additional demand or not. Nadia?
Yeah, I think that's makes a lot of sense that this is what's going on. LA County, the number of uninsured in LA County is quite high. With the advent of the ACA and expansion of coverage, we still have a pretty large uninsured population that has not, some of them are not eligible to participate, and some people, perhaps the outreach has not really worked yet sufficiently to get people to be covered. So people who don't have, the longer you haven't had coverage, when you do want to get care, you have barriers, and so and you don't have the money to go and pay out of pocket. So the chances of poor oral health in the low-income population is higher, and the demand for the population is higher. Remember, we only looked at the overall organization. If I was able to, if I had calculated that ratio by the total patient population in a given clinic by dental provider in that clinic, that ratio would be even bigger. In other words, a lot more people there per every dental provider, and that definitely is an indication of not sufficient capacity.
And I would say, just looping back to Gwen's question, part of it is that I think it's the way that either the centers themselves or that people have looked at the services provided in these centers, right? So by and large, there's a greater emphasis within the clinics, on the dental clinics, in treating adults. And oftentimes it's treating adults when they have a problem. So, they're really not getting routine care. They develop a problem. They know they can get somewhere and get the problem addressed. And what we're trying to do is to shift this to really a more preventive and primary care mode, with efforts even as including dental services within the patient-centered medical home, so that we can, dismiss this old adage, which is another part of the answer of why this has been a problem. It's this attitude that they're only baby teeth, they're going to fall out anyway, it doesn't matter, rather than understanding what we're dealing with is the precursor of a lifelong disease process, and these are opportunities to get these kids started in a much more positive way.